I want to welcome, ladies and gentlemen, distinguished guests in our roundtable organized by the BEBA and the EBCC in honor of His Excellency Dr. Mohamed Eldin, Advisor to the President for Health Affairs. And also I want to welcome Dr. Magdi, the President of the Egyptian Medical Society in UK, as well as Professor Mahmoud Metini, President of Ain Shams University. Thank you for joining us. Given the current circumstances, I'm sure that many participants will find this roundtable beneficial. Also, I want to thank the Egypt Week sponsor for their support, Benia and EFG Hermes and HSBC and SAP. Our roundtable meeting today will highlight on the healthcare sector in Egypt. As we know that Egypt is one of the few emerging markets for which we expect an annual output to continue to rise this year and next. Forecasting for this year is expected to be the gross 2.6%, and next year expected to be 3% in 2021. Thank you. Dr. Magdi, the floor is yours.
Thank you very much indeed, Dr. Maged, and it's a pleasure to be part of this. I wrote to you and I sought really to talk about COVID-19 in UK and Europe in general, and basically what will be the economical effect of COVID-19 on the healthcare sector, and how it really, because the financial or economical effect on healthcare sector, both in the public sector, will be totally different from that of the private sector. So let us start by really the situation in UK, which is very similar to many places in Europe. I mean, France, the same thing, Spain, Portugal, Denmark, Germany, even having a lockdown. So we are basically Europe now becoming more or less the epicenter, the new epicenter of COVID. In United Kingdom, the positive number of cases tested so far was 1.2 million. The Office of Statistics really put this number higher than that, but the positive number of cases is 1.2. That represents basically about 2.3 of the world cases, which is really currently, we stand at 50 million, 0.5 people who are infected with COVID-19 worldwide. The total number of deaths in the United Kingdom have reached the 49,000. That's really from the beginning of March till today. And that represents, sadly, about 3.8% of the total number of deaths, recorded deaths worldwide from COVID-19. Of course, you have to take these figures with slightly pinch of salt, because there is a lot of country not doing enough testing. So we don't know exactly the actual number of people infected by COVID-19 or how far it is spread. In July, we were hoping we're coming out of the 3 months lockdown, and all the figures in terms of deaths, the rate of infection, which they call the R factor, transmission, and hospital admission, and every number of deaths was really showing was coming down. And out of the 300,000 tests we do every day, the number of people infected with COVID-19 was in the average daily was 20 1,000 per day who are tested positive. And as a result, the hospital admission went to about 1,400 per day. So you can imagine if they left the case, if they left that scenario to go on unchecked, the hospital admission per day of 1,400 will eventually have blocked the system, and the NHS would not have coped but the number of people who require hospital admission. In short, we find the correlation between the number of people who tested positive, that 7% of all those who test positive will require hospital admission or have been actually admitted to hospital. And out of this 7%, there was about 9% who required a ventilation. The rate of death in this peak is far less than the one we had in March and April, and that's because we have learned a lot about the disease. The use of dexamethasone have reduced the people requiring ventilation, and we are managing the disease in terms of treatment much better. So the number of deaths relatively less than what it was in March, April, May. So far, the UK government, to mitigate the economical hardship of the coronavirus, have spent $275 billion. That's actually what's been spent today to mitigate the economical effect of corona. But we need really, there's a vaccine coming in the way, and we may see the hope by March, April, will be able to vaccinate a big bulk of the population against the corona. But what is life after the corona? Let's assume we managed to have controlled it. Look at it this way. The French government would have borrowed up to 106% of their GDP due to the public increase in the public debt.
Okay. Thank you, Dr. Magdi. Dr. Mahmoud, the floor is yours.
I would like to thank the BEBA, headed by our dear friend, Mr. Khalid Nusser, and all members of the BEBA, and of course, my dear friend and brother, Mr. Maged El Menshawy, for inviting me to be with you today. It gives me great pleasure. Thank you very much for that. And I think the topic about today was about to speak about the healthcare at large. And currently being the president of Ain Shams University, I said maybe it will be appropriate to start a little bit by sharing with you a bit about Ain Shams University, where does it stand and everything. And the second part of my talk will be about the COVID-19, the current healthcare challenge that really surprised the whole world since December 2019 to date, with no exception in the planet. Obviously, I'll be more than happy to discuss the healthcare landscape in Egypt from different angles, and the total reform Egypt is witnessing over the past few years, I would say 5 to 6 years, when both healthcare and education, the two pillars of any development and modernization, started. As we all know, the healthcare expenditure went up to a little more than 4% of the GDP, and this went in the same, aligned by several presidential initiatives by His Excellency President Fattah al-Sisi, the 100 million healthy citizen, Egypt free of HCV, which can I speak about it until tomorrow, because of course it touches my background specialty, screening of different types of cancer, first of which is a breast cancer with other cancers, the women well-being at large and the healthy Egyptian woman, and many other actually presidential initiatives that took place over the past few years very successfully. And all these initiatives, of course, converge towards the newly implemented few months ago, or at least more than 1 year, health insurance law that started in Port Said and extending now to different governors. Healthcare insurance existed in this country. First, I would like to tell you a little bit about the, maybe most of you are aware, how healthcare is divided in Egypt, and with a very diversified portfolio between the Ministry of Health presenting its services, the university hospitals carrying a big brunt, at least 44 to 50% of the tertiary healthcare needs in terms of big interventions like open hearts and organ transplant and so forth, and the private sector, which is out of the pocket, which is used to be quoted at least around 60% of the healthcare expenditure in this country. And of course, beside the private sector, is university hospitals and the Ministry of Health, we have also several authorities and ministries that have got their own hospitals and own health insurance system, like the army, the police, the Ministry of Electricity, and so forth. Now the decision to make it a rather universal health insurance to replace this dissociated system or divided system, I think was a very sound decision. It was, there are a lot of challenges, obviously, that exist, but we are overcoming it day after day. 3 authorities have replaced the existing insurance authority that used to belong to the Ministry of Health. Now 3 new authorities that is not belonging to standalone, totally autonomous, namely the healthcare authority, and another one for the expenditure or paying as a third party, and the third one for governance. And I think they are taking very active steps on this. If I may now come to the presentation and share with you a little bit about
Oh, it's clear. Yes, sir.
Okay. Yes. So I would like to share with you, as I told you, the first part of my presentation about Ain Shams University at such an old university that started 70 years ago, since 1950, under the name of Ibrahim Pasha. And we are very, sometimes they are very proud saying that it dates back 3,000 years BC, under the name of Ain University, when Ain Shams University existed in the very same geographical place that it existed right now. Ain Shams University, I've got 15 faculties and 3 institutes, encompassing 8 campuses, and we have got 13 hospitals in belonging to this university, and they are carrying one of the main branches of the tertiary care, healthcare in Egypt, as I said, and in COVID-19 they played a big role about that. We have several centers of excellence, the Ain Shams Medical Research Center and the Center for Drug Research, beside other centers, of course, but maybe these are the 2 centers of excellence concerned with the healthcare. We have a lot of international collaboration, and I think the participant, at least two of the participants in today's meeting are within our international collaboration, the Great Ormond Street Hospital and the Royal Brompton Hospital. And as you can see, the international collaboration in Ain Shams does everything across the board, from student exchange to faculty exchange to joint research to everything. And we are having this international collaboration mainly with Europe and with Asia, and at least with 12 centers in North America and in Africa. We are trying to change Ain Shams University very rapidly to be a smart university as rapidly as possible, and doing that, we started the state-of-the-art data center, and we introduced the university management system so that everything could be automated, from the e-payment to the question banks to the LMS, to the e-resources booking, to the quality tracking, to everything. Accreditation, Ain Shams University, the 15 faculty are locally accredited by the NACA, which is a local body for accreditation of the university bodies. And in terms of international ranking, Ain Shams University entered all kinds of international ranking, whether it is the QS or the Times Higher Education, or it is the Shanghai. And as you can see, it's anywhere between, always between 700 and 800 worldwide. When it comes to medicine and life science, we're very proud that this year, for the very first time, the Faculty of Medicine in Ain Shams University has been ranked as between the best 200 in the world, that is between 176 to 200 for the very first time. Of course, our plan is to be within the best 100 in 2023. There are growing demands of higher education opportunities in this country. And if you can, this graph, the panel on the right-hand side of the screen is very obvious about the numbers that we need. And by 2030, nowadays we have at least 3 million in students in different universities in the taking higher education in different public and private universities. And the number needed by 2030 will surpass actually the 4 million figure. And we have a lot of challenges for this growing demand. That is, of course, the limited resources, need for improving of the ICT infrastructure, especially after what happened over the past year, facing the COVID-19 challenge. Accreditation of all our degrees and programs. And of course, we need, of course, to touch on our real legislative hurdles in our higher education system, because the law governing the higher education since 1972 have got a lot of hurdles that needs to be touched and maybe even changed. In terms of talents in this country for the youth, we are blessed by our young in Egypt. We have 62% of the population below the age of 35, and if we take the higher education between 18 to 22 years at least, we have 8 million young seekers for higher education. And if we look to the talent surplus or talent deficiency map worldwide, as you can see, Egypt is blessed to be within the group of countries with talent surplus, the strongest trend, and compared with the USA or UK, where there is some sort of talent deficiency, obviously because the number of young and youth are much lesser than in Egypt. What are the strengths and opportunities for Ain Shams universities in the landscape of higher education? It have got an excellent international reputation and recognition. It's highly qualified, dedicated faculty. We believe that we have a good community trust with good relations with all NGOs, and we have existing regional and international collaboration, as I just showed you. Coming to the hospitals, Ain Shams is a referral hospital providing all levels of medical care with 7 hospitals and 6 medical centers. We're having 4,000 beds. And we are accommodating 1.5 million outpatients per year, a huge number, with 150,000 inpatients per year, with all kinds of interventions, surgical or non-surgical interventions. We have the first geriatric hospital in the MENA region, and we have a very high success in organ transplant and, at large, and namely, of course, liver transplantation, and an outstanding psychiatry center. This will take me, of course, to the COVID-19 mitigation in Egypt and the Ain Shams University. We just heard a lot from my dear friend, Dr. Magdi, about the COVID-19 in England and the mitigation steps that are being taken there. In Egypt, actually, one of the countries that faced the COVID-19 challenge, I would say, very bravely and very efficiently. And Ain Shams University had got a clear impact in these mitigation steps that I would like to share with you. At the beginning, the first 2 to 3 months, as you can see, from February, March until August, the number were rising, like it's evident in this panel on the left side, and the curve of the whole world is not bending. Actually, it bended, as we'll see shortly, but again, now we are speaking about the second wave or an extension to the first wave. Anyway, we are seeing now that the numbers are increasing. The challenges that we were aware of at the beginning of this COVID-19 pandemic, when it arrived to Egypt in February 2020, that we are very much aware of the norms, habits, and the habits of Egyptians, and that we had an awareness problem. Nobody was aware enough by what is COVID-19, how can you protect yourself from it, what are the symptoms and signs, what can we do facing it, etc. The healthcare workers concerned and panicked. The young healthcare, the residents, the young doctors, the nursing staff, the technicians, everybody was worried and panicked actually at the beginning of this experience. The PPE shortage, we never faced a condition like this with an enormous need for PPE on daily basis for everybody and for every patient to be changed as frequent as possible from hour to hour and from day to day. Of course, the medical supply chain interrupted in a way because of the travel bans. The testing issues in terms of availability, cost, and whether we should pursue a mass versus target testing. And of course, in our country, we never pursued a mass testing policy. And last but by no means least, the flood of conflicting and rapidly changing data. And all of us witnessed this, that every day, whether from the WHO or from any governing body in the world, the data was changing very rapidly. And the big question was, in any country, was to do a total lockdown or a partial lockdown or no lockdown at all, with, of course, the economy-driven policy versus the medical safety policy, always in the mind of the decision-making and the policy makers in a given country. When it comes to Egypt, Egypt is a big country, as we all know, 100 million plus population. Health expenditure went up to 4% plus to over 210 billion Egyptian pounds. At the very beginning of the COVID-19, when it arrived to Egypt, as I said, February, beginning of March, President Fattah al-Sisi allocated immediately 100 billion Egyptian pounds to face the COVID-19 pandemic. And in a country that we know that there's at least 30% below poverty line, and the adult illiteracy is around 20%. Why I'm quoting these last two points? Because when we speak about home isolation and social containment concern, which all countries pursued from the very beginning, we didn't have this luxury at the beginning to convince people to stay at home whenever they contract the virus. And that's why we took a different path than other first world countries at the beginning. Nowadays, everybody is convinced, and the panic vanished after 9 or 10 months. And now people are convinced to stay at home and to pursue the home isolation. But at the beginning, it was very difficult to convince anybody who contracted the virus to be isolated, even if it's in a good condition with no symptoms at all. How did we manage at the beginning in Ain Shams University? We realized that Ain Shams University must take care of 3 million Egyptians plus an unknown number of COVID cases. Why I'm saying 3 million Egyptians? Because Ain Shams staff, administrative body and students are around 300,000. In our university, we have 250,000 students, 14,000 faculty, and around 30,000 administrative body. It's a huge number. These 300,000 Egyptians, if you imagine they have a family, each and every one of them of 3 to 4 persons, we speak about 1.2 to 1.5 million Egyptians. And as I just told you, that we are receiving around 1.5 million patients in our patients and emergency rooms per year. This comes up to 3 million Egyptians that we felt a moral responsibility and an ethical responsibility toward them. We have, as I told you, 4,000 beds, and we have 4,500 doctors, and our hospital beds per 1,000, around 1.3 which is not far from the World Bank formula. The first reaction was to raise awareness. We, under the slogan of stay at home, stay safe, within Ain Shams community and in the surrounding community, whether Eastern Cairo or Greater Cairo, we did lectures by our infection control team that went everywhere, telling everybody with videos, with explanations, with lectures, with meetings, what is COVID-19, how do you get infected, how to avoid infection, everything about hand washing, social distancing, masks, and etc. The second reaction was to do massive disinfection campaign within the campus, all classes, labs, every corner in the university and the faculties, regular and ongoing, adjustment to working conditions, everything went on online. So, and we first we reduced the working capacity to 50%, and then maybe 25% as time went on. And working from home was the norm. On the 15th of March, the country took the decision to suspend the education process in all universities and schools, and the students stayed at home. And we started PPE manufacturing in-house in the university hospital, because we were aware that we cannot get from the market all our needs. So we manufactured some of the masks and the gowns within our university hospitals. We started the first quarantine hospital, that is the Al-Abur Hospital, with a 70-bed inpatient and a 41 ICU. This was the first university quarantine hospital. I hate the word isolation hospital, I prefer quarantine hospital, that served the Ain Shams personnel, families, and the surrounding community. And when the numbers went up, we added another hospital, that is the geriatric hospital, with the numbers you can see, ER hospital. And if you can see on the right-hand side, by May, June, we saw that the number, and there is a surge of cases, the number is rising very rapidly. So we took the decision to build the very first field hospital that is on down here. This is the field hospital here. Very first, I would say civilian field hospital. We are always accustomed to the military field hospital, but this was a civilian university-based field hospital, 165 bed with 11 ICU. So we ended up by 319 bed inpatients and 104 ICU. And I think this was a very reasonable number to serve our community. And the numbers rose again. So we went to the dormitory and we dedicated 480 beds for the asymptomatic mild case to end up nearly 800 beds. This is the daily dashboard that all of us received every morning. Higher administration of the university, all the deans, the higher personnel in all faculties, to be aware of the numbers day by day going on in terms of number of patients in the ICU, number of patients recovered and discharged, telemedicine, and everything. So that we, in total, since 1st of March to date, until yesterday actually, Ain Shams University served 8,445 patients. 400 and nearly 5,000 of them were served from home through the telemedicine. We have a very strong telemedicine department with Ain Shams virtual hospital. So 57% of our patients were served at home by online and daily telephone calls and following up over the phone. And admission were for 43%, around 3,500 patients. The recovery, as you can see, around 90%, nearly 8,000 patients, and still admitted to date is only 56 patients, 38 in the inpatients and 18 in the ICUs. The death rate or the fatality rates were 7%, but who's related to the COVID were only 3.6%, and the 34% was non-COVID related. This is a complicated slide. I'm sorry to share with you, but I think it's very informative because this is a paper we just mentioned in the International Journal of Epidemiology that tells you the whole story in one slide. What's written here in brown is everything, all the mitigation, all the steps taken by the country. What's in blue is the coinciding mitigating steps that we took in Ain Shams University. So as you can see, the first COVID case diagnosed in Egypt was in the 13th of February, and while the first in Ain Shams was in the 25th of March. And the schools and universities were closed in the 15th of March. The 50% reduction in the workforce near the same time, and the suspension of the air travel. We in Ain Shams in 19th of March suspended all elective procedures, and outpatient clinic visits were reduced to 50% first, and then we suspended totally in the 1st of April to be concentrated only on the COVID-19 cases. And as time goes on, you can see the steps to mitigate all the effects of the COVID-19. Here's the bars. This is the very first, maybe worldwide, screening for all healthcare workers within a given facility. Our 4,000 plus doctors, nurses, paramedics, technicians were all screened for COVID-19 by rapid test and by PCR for the very first time. And that's why this publication went very rapidly to be published. And our infection rate was around 4.5% globally, highest in the nursing staff, around 6%, lowest in the doctors, around 1.5% to 2%. Again, this is our triage cases. We had a very efficient triage at the entry of anywhere in Ain Shams University. This is the brown curve downwards. You see the triage where we try to see all patients, all walking in patients, all newcomers, and we do a test for them, and we do an examination, and with any suspect case, this is the number of the triage, and the suspected here is the brown. We go and do the PCR for them. And as you can see, the numbers went up, and our peak was in June to beginning of July, when the curve started to bend here, and the number of the suspected cases went down. What's good about that, I want to share with you, is that people were during the whole of March, April, May, June, and July until August, people were refraining from coming to the hospital. The usual patient, the chest pain patients, the whatever patient away from COVID, were afraid of coming to any hospital or ER from the fact that they might contract COVID. So they were refraining from coming to the hospital, actually. And we found our ICU that used to be packed, our ORs that used to be very long schedule, empty. So by this time here, everything went to normal. So you can see the triage cases went up and the suspected cases went down, meaning that the COVID-19 was in a way disappearing or decreasing in number, was gaining confidence again in the hospital, and the number rose again. But again, nowadays, we can say, I can tell that the numbers we can witnessing, it's increasing. Thank you very much.
Sorry for the interruption. Dr. Awad, it's a great pleasure to be with you. And the floor is yours for your presentation or your lecture.
Now we are in the era of both the seasonal influenza and the era of COVID-19 infection. And as you know, many of the symptoms of COVID-19 patients are very similar to the seasonal influenza. There is two important issues related to COVID-19 disease or virus. The first one, that it's more infectious than seasonal influenza. Also, it's more infectious than the others, other coronavirus infections. The infectivity here is higher because the average infections in seasonal influenza is 1.1 to 1.5 patients. I mean, each patient can infect 1 to 1.5 person. And also the other important point is that the incubation period here is around 14 days, which is very longer, and it is near the infectious incubation period of Ebola virus. Every week we have a sort of committee, high committee for managing the problem under the supervision of His Excellency Prime Minister of Egypt, and all the ministers related to the problem were engaged in this committee. And personally, I attended every meeting and put a strategy for management of each stage of our problem. And then, as mentioned before, the number of cases declining, and so that we have preparing ourselves for any possibility of increase in the number of our patients. Also, we put the possibility how to make trials for and training of our staff for the management of any possibility of increase in the number of our patients. Up to now, with all the country under the umbrella of His Excellency President, and he is also managing, and follow-up is very strict to manage the problem. We use the masks in the general areas. We use also the protective mechanisms, and with certain recommendations by law to prevent as much as we can the spread of the disease. And we are ready to any question from the participants.
Thank you.
I just wanted to follow on from Dr. Magdi in relation to what he said. So in the United Kingdom, we are seeing more cases of long COVID, and there's a study out to look at the impact of long COVID and the longevity of patients coming back into outpatients. And what is Egypt's thoughts around long COVID, and have they thought about what impact that's going to have on the health system?
We define this problem as post-COVID syndrome. Post-COVID syndrome, yes, post-COVID syndrome is already recorded here in Egypt, not only in the chest symptoms, but also sometimes in neurological symptoms, psychiatric problems, persistent myalgia, persistent psychosis, which is recorded. We understand that. Another problem which is very important, you mentioned, is that after resolution of the acute problem, we have some cases of persistent ground glass in the chest radiology or CT, and some sort of interstitial fibrosis. And this is persistent for a long time. Usually we treat these cases with corticosteroids, and there is improvement, but it is a slow regression of the disease.